Everyone. I'm Anik Gosselin. I'm a clinical psychologist and forensic neuropsychologist. Today, we'll talk to you about my experience with individuals who come into conflict with the law and who are suspected to have or who have been formally diagnosed with fetal alcohol spectrum disorder. So I'm going to use FASD as the umbrella term for all. We know there's all different terms for different level of severity for FASD. I'm going to refer to this just for practicalities as FASD today. So I'm going to talk about the mental health services at the Royal as well as the bigger organization, but I more specifically will talk about my own experience. I'm not specialized by any means in FASD, but as I will explain to you, in my role as the clinical psychologist in corrections and in forensics before that, I have encountered a lot of individuals who have either been diagnosed or suspected to have FASD. Sometimes, sorry, my slide don't want to change. Okay, sorry about that. So just a bit on my background to tell you how all this happened, how I came to be where I am. I'm a University of Ottawa PhD graduate from the clinical psychology program, and I specialized in forensic and correctional psychology and clinical psychology and in neuropsychology. And this piece is important because I have a lot of referrals for neuropsychological assessments with people who are suspected to have FASD. My professional journey, I wanted to talk to you a little bit about that because I didn't start my career wanting necessarily to work in correctional or forensic settings. My background is actually a specialty in my PhD is in the impact of sleep deprivation on the cognition in the brain. It's like attention, memory. So what happened is when I finished my PhD, there was this job in Brockville, an hospital job, and I've always been a team person who want to work more in hospital setting than in private settings. So also help people who I find it's different. People in the private sector tend to have more services, more access to psychological services, whereas in hospital settings, when they end up there, often they don't have this access in the community. So I was interested in wanting to help those who are the most in need and often don't have the access. So I ended up taking this job in Brockville, which was in forensic. So forensic is a bit different than correction. And the main difference is patients have come into conflict with the law. So they committed an offense, but they were found not criminally responsible because of a mental health, a severe mental health disorder like schizophrenia, for example. Whereas in corrections, they came into conflict with the law and were found criminally responsible. But in both cases, forensic and corrections, these are individuals who came into conflict with the law for different reasons. So I ended up there, did a specialty in forensics. This is where I started to know about forensics. I took courses in Carleton with Dr. Adelfort, who's like very well known in the field. Then I left and I had other experiences. I wasn't sure at the time if I wanted to stay in forensics. I really liked the population, but I went to the Montfort Hospital and I worked in a clinic specialized for people with borderline personality disorder. This was in general psychiatry, so not in forensic anymore, and also doing neuropsychological assessments. And then I left. I came back to the Royal at the OSI clinic, which stands for Operational Stress Injury Clinic. This is for veterans, military veterans with operational stress injuries, so war traumas, things like that. And then I was missing the forensic field a lot, I guess, once you really like to work with this population, because there's so much need for them there. My husband and I decided to move to Brockville, and my husband is a social worker, and to devote our career to the Brockville site, where we have both a forensic unit and a secure unit. So I've been doing forensic and working in forensic and correctional settings since 2012, where I do diagnostic assessment, the neuropsychological assessment piece particularly, but also psychodiagnostic, diagnosis personality disorders, diagnosing other mental health disorders. Often the psychiatrist will consult me to clarify the clinical picture when they're not sure. So I'll do my different tests and come up with a differential diagnosis opinion. So I also do the treatment using evidence-based. So everyone have heard about CBT. This is one of my interventions, but obviously there's other evidence-based intervention as well that I can use: emotion-focused therapy, motivational interviewing. And I do research and program evaluation within the forensic and correctional setting. So I was in the forensic, which called the FTU, from 2012 until 2018, and I've been at the STU, the Secure Treatment Unit, so the psychiatric jail, since 2018. So where I am now, the Secure Treatment Unit is a 100-bed facility with 4 units. So we have the assessment, more secure unit, and then we have 3 other units: the anger unit, trauma unit, and the sexual offender. And also we have a lot of individual with lower intellectual functioning that are on the same unit, but separated. So the mission, the Secure Treatment Unit was created in 2003, and it's a partnership between the Ministry of Health and the Ministry of the Solicitor General, so corrections. And the mission is to treat provincial offenders with severe mental illnesses using an evidence-based model. It's called the risk-need responsivity model. And the overarching goal, of course, is to decrease recidivism, but by treating mental health and by providing support, helping to provide support in the community. We believe this is how we have the best impact for recidivism. So we have very extensive discharge plans for our guys, which is very, very different from other jails in the province. This is a provincial facility, so the offenses, they're with us for less than 2 years, so 2 years minus 1 day is provincial. So often we have them for just 5-6 months. So my involvement with people with FASD is, I'm going to say it's indirect, in the sense that, so what happens is we have our guys, they committed an offense, they got in trouble. A lot of them have problems with substance abuse, behavior problems, impulsivity, conduct disorder, and of course all the ADHD. They have such a long, like, of course, schizophrenia too. Some have schizophrenia, some have bipolar disorders, all kind of usually severe pictures. And what happens is sometimes we'll have somebody in the file, it will be indicated, oh, this person has a suspicion of FASD, or there's a diagnosis. I'm going to say more rarely. So when I see that, I mean, of course, this is one of my go-to, okay, this is what's going on, and this is potentially what's going on. And then I'm going to dig further. I always try, of course, to talk to a caretaker to get more information. It's very difficult to confirm. I cannot tell you how difficult it is. So often it's a provisional, if you want, diagnosis, because the features change. Often you don't necessarily have the facial features anymore in adulthood. The family, the mother is nowhere to be found. Even if we can talk to the biological mother, even then, we're not too sure how much they're gonna admit to how much they were using during pregnancy. So a lot of challenge with confirming diagnoses. But when the clinical picture point to, so this is what I really try to do a lot, is when the clinical picture point to, okay, I have this evidence, this evidence, this evidence, this evidence, then I feel pretty comfortable to say this. I actually just in the process of assessing a guy who there's a strong suspicion of FASD and no facial features per se clearly, but with all the challenges he has, it's very consistent. So at some point we have to make how can I say, make a professional judgment and opinion to say it really looks like it, even if we cannot absolutely without a doubt confirm it, which is so rare that we're able to as adults. So usually my referrals are for ADHD. So the person will come to me, oh, the psychiatrist will ask, can you confirm ADHD? Can you check, is it something else? A lot of guys have substance abuse problems, so they sometimes want Ritalin, they want medication, they're seeking medication. So the psychiatrist is like, I'm not sure if it's ADHD or is the person wanting more meds. Intellectual disability, a lot of them will come to me, can you do an assessment to confirm intellectual disability? Is there something else going on, or is it more just antisocial personality disorder or conduct disorder? So this is how they typically come to me. I'm just going to speak a little about the Royal's mental services for FASD in general as well. So this is at the STU, how they come to me. I just want to specify to this group what we have for FASD. We don't have a clinic per se. I know there's 21 clinics throughout the province, and there's one at CHIO specialized in diagnosing FASD. We don't have that kind of service at the Royal. So what happens is the people who suffer from FASD will end up in one of our specialized clinics. So somebody, if they have developed psychosis, they'll end up maybe in the schizophrenia program. If they committed a crime, they will end up with our program. If they have intellectual disability, they will end up with a program that's called ACT-DD, dual diagnosis. So typically what happens is they have a severe mental health condition that will make them end up in one of our programs. And this is where we can identify them and hopefully then connect them with services in the community. So we, of course, use formal criteria to confirm the diagnosis whenever possible. Like, I'm not going to teach this group about the criteria. I'm sure you could teach me more, but you know, there's 4 criteria to, without a doubt, confirm. But it's, as I mentioned before, difficult to diagnose in adults. So the facial features, some growth retardation, if it can be confirmed during the development period, that really help. Any abnormalities of the central nervous system, and of course, confirming that the mother drank alcohol heavily during pregnancy. Sometimes not that heavily either, but your group can speak better to that. But from what I read, it's not just about heavy consumption that somebody developed FASD. So again, a bit like I said, like FASD etiology can lead to many different clinical pictures associated with many comorbidities, and the mental health services will depend on the diagnoses and the comorbidities, obviously. I prepared this slide for you guys because I thought it was, like, I mean, it speaks so loudly about how someone with FASD has all kind of difficulties, prevalence, extremely high prevalence of neurological and mental health issues that develop as a result of FASD. So if you see here, you have like, this is like stunning, conduct disorder, 90% prevalence for FASD, which in the general population, it's 9%, so 10 times more. So no wonder they end up more in the jail system because they have, I'm going to say bad behavior, but not in a term like difficult to manage behavior as a result of FASD. Receptive language deficit, expressive language deficit, like 80%, 76% compared to 7% in the general population. So this is sometimes where they end up with me. This is something I can diagnose when I do a neuropsychological assessment. I will assess the language abilities and be able to determine if there is a receptive and expressive language deficits. A lot of people, but not everyone. So it's important when we talk about prevalence, it's important to not exclude FASD, for example, based on the fact that they don't have intellectual deficit, for example. So because the prevalence is high, but it doesn't mean it's there either. So we really have to look at the bigger clinical picture. So some of them, yes, will have intellectual, mild usually, intellectual disabilities. And when I say mild, there's standard definitions of mild, moderate, and severe. Severe would be bedridden. So the person is, the brain doesn't do much, cannot learn. Mild, you have somebody who can still learn, but we're failing in school, we're in special classes, are not able to function by themselves, but with help. They can do it. Like, for example, finances would be difficult to do for them, or taking care of hygiene or any decision making, like tends to be more poor, things like that. But they can still work with proper structure. So anyways, just to say, developmental cognitive disorder, mental deficiency are 69% prevalence compared to 0.71 in the general population. So this is absolutely huge. Alcohol, drug dependence, very, very prevalent, 50%. Often they end up with us in jail as a result. So not crimes that are like horrendous. It's more like they get in trouble because of the drug abuse or dependency. And then we need to find ways to help, not to punish. So anyway, alcohol, drug, 54% compared to 12% in the general population. Also, attention deficit hyperactivity disorder, they come to me a lot for that too, as I said earlier, 50% prevalence compared to 6% in the general population. So a clinical picture, complex, multiple problems. Just to say, for us, I'm going to estimate that we don't keep track of the formal numbers of who is referred for FASD, whereas the history of FASD per se, because it's so hard to confirm, for one reason, and second, because it's from birth, and in psychiatry, we tend to focus on the symptoms now. But I'm going to say about 10 to 15%, maybe 20 of a history or suspicion of FASD. This is so high compared to the 1 in 33 child who's estimated to be born with FASD in Canada. So we get a lot of people with much more in the jail system than the representation is in the general community. So it speaks loudly to they need help. So I didn't put it in that slide because I focused, of course, more on the psychiatric, the resulting psychiatric condition as a result of FASD. But there's also all other kind of comorbidities, congenital, such as sensory neuronal hearing loss, visual impairment, chronic serious otitis, things like that. So sometimes, even though it's not a psychiatric diagnosis, it can help to confirm or point out to the fact that it looks seriously like it's FASD. So when I do an assessment, my major goals are to clarify the diagnostic picture, of course, always in the idea of informing treatment, and also referral to services in the community. So we believe, I certainly am a strong believer that when you have enough support in the community, that's the best way to stay out of trouble. And I always tell we call them at the STU, we call them residents. We don't call them inmates or offenders. We call them residents. They're our residents. So I tell the residents I work with that we want them to have a fulfilling life with the optimal life and never come back to us. So of course, the referrals depend on the diagnoses. So if we're able to confirm intellectual disability, then I'm able to refer to the Developmental Services of Ontario, and they have a plethora of very good comprehensive services. So usually for us, it's almost a success when I'm able to confirm there's an intellectual disability, because we know with Developmental Services of Ontario, they have housing opportunities, they have support. So usually that's, I mean, of course, the person needs to have intellectual disability. We're not going to confirm that if they don't, but at least they get the services they need. Conduct disorder, any other psychiatric diagnoses, we can refer to Canadian Mental Health Association for support in the community. ADHD, well, medication can help, and if possible, psychotherapy to help them learn to manage their diagnoses better, their symptoms, better. And if they have a substance dependence, try to find support and treatment in the community. Unfortunately, people with FASD often who come into conflict with the law and you come to us, they overwhelmingly tend to have less support in the community than the average person. So we were talking earlier about how FASD also comes not only because all of the neural deficits, but this is a child who even before was born was neglected, and the least say is neglected. So it almost comes with a trauma inherent to being treated like this and being not loved, because this is lack of love to treat your child before they're born like this, in a way. Or I shouldn't say that. Some people have all kinds of challenges themselves, and sometimes they want the best, but they're unable to. So, but certainly from the child's perspective, there's at the least to say there's neglect. And of course, often they were not raised with their biological mother. So we tend to have more difficulty with having their own support. So we really need to find them support when they return to the community. And often, like the person I'm working with right now, this is what I mean, he was so happy when I said, we're gonna, really try to have enough support for you, because he's literally alone. And how can you not get in trouble if you have you already have like some challenges with mental health and neurological challenges and no support. So support is tremendously important. So unfortunately, as you know much more than I do, services in the community are limited. But family and caretaker support is tremendously important, and clearly research demonstrates it's a protective factor for doing better, optimize your abilities, staying out of trouble, things like that. So I feel you know more than I do about those, but there are services in Ontario, and I read quite a bit since I spoke with Rob the first time, and I was happy to see that there's like 21 clinics specialized in assessing and diagnosing FASD, which is tremendously important because once you know the diagnosis, it's so much easier for the caretakers to learn, deal, help, understand, and for the person too, it's like, okay, this is why I act like this. Like I have a FASD, and it's the beginning of getting better. It's the diagnosis. It's certainly not sufficient, but it's necessary. And often, my experience is diagnoses come with help. Often, without the diagnosis, people are like falling between the cracks and never completely understood. So diagnoses are very important, but certainly not sufficient. So that's my story I had for you today, but I am happy to have a conversation with you guys and learn about your expertise as well. Thank you.
So thank you very much, Dr. Gosselin. We have definitely been looking forward with great anticipation your presentation today. This has just been so incredibly impactful. The two things that really jump out at me is I was certainly familiar with the prevalence numbers that came from Dr. Popova's study, but I had never seen the comparison against the general population before. And that was extremely eye-opening to me, to know that conduct disorder only exists in 10% of the general population versus the 90% with people with FASD. Same way with intellectual disabilities. It certainly gives us a really good understanding of some of the challenges that our children are facing, some of the challenges that some of our members are facing, and helping us understand that. And again, thank you for this really great overview of the Royal and all of the services that they have to offer. You are a great spokesperson on their behalf. Your compassion, your empathy really came through today. So we very much appreciate everything that you brought.